And you can look
I'll
over
just
my
look
shoulder,
over
yeah.
you. Yeah,
So
okay.
Dr. Jacobson is the chief of the STD control branch at the California Department of Public Health, where she supports the administrative, programmatic, scientific, clinical, disease investigation, policy, epidemiologic, and surveillance teams for STIs, hepatitis C, and Mpox for Californians. As a former chair of the California COVID-19 testing task force, she oversaw the rollout of thousands of testing and test to treat sites across California. She serves as the disaster medical assistance team for the U.S. Department of Health and Human Services, responding to natural and public health disasters, and is on the board of directors of the HIV MA for IDSA. A recent senior HIV TB care and treatment advisor for the United States Center for Disease Control and Prevention to the country of Uganda. She contributed to the revision of their national HIV TB guidelines, delineation and uptake of new diagnostic algorithms. The previous medical director of the LA region PAETC. She has extensive experience in workforce development, capacity building, and technical assistance to clinic systems and emergency departments. And here's where a lot of us know her. She was an associate professor of clinical family medicine at USC, where she was the PI of multiple studies on HIV testing, rapid treatment, and PrEP implementation, and also a lot of other things at the medical school. Finally, with the University of Washington, she was the HIV TB clinical mentor to the healthcare providers in Namibia, in a region with one of the highest global HIV TB co-infection rates. There's more, but I mean, this is amazing.
Long enough.
And we want to hear you speak. Okay, sorry, I keep hearing here. Thank you. Let me turn this. All right, so with that, we're gonna turn it to you. I will try to share my screen for anyone over here who wants to watch. And Kathy, if you, I guess you don't need to stand and look at your slides, whatever you'd like to do.
But so I'll try to do it.
Oh,
today.
okay.
So first of all, Jill, thank you for inviting me. I know Jill now for what, I guess about
15 years, yeah.
Yeah, first met her when she was a fellow, and we worked together on the CDPH implementation studies. So thank you for inviting me, and so maybe before I even start, how much time, when do people have to leave? Because then I'll cut various.
Yeah, sorry.
No, that's fine.
I mean, we usually try to have the speakers wrap up 45, 50 to allow for questions and like real hard stop at 9. But I know you're also meeting with a few, yeah, because people have to get to clinic and stuff. So I think 8:55 would be the pushing it. And the big question is, do you want interruptions while you go, or would you rather wait till the end for questions?
I don't care. Really.
Okay.
If people want to interrupt, because I can, honestly, I can always come back and do the second half if I run out of time.
Yay!
No, because I've done that before.
Okay,
Yeah,
all right, well,
So,
that's great.
happy to do so. So I will just start and, yeah, good morning, everybody. So I'm going to talk to you about the emergency department screening program that CDPH is implementing and also test to treat in the emergency department. In order to do so, I really need to cover some historical data, which will probably be, history for all of you, but it helps sort of set the stage. Then I'll explain the emergency department screening program. Then I'll walk through test to treat, first for syphilis, then HIV, and then Hep C via cases, and then wrap up, if we get there, with current California surveillance. Okay, so starting first with syphilis. So if you look at the early syphilis incidence rates for California, historically they have either mirrored or slightly preceded the US incident rate. But if you look at around 2009, 2010, and I guess you can't see this, but on the slide, you'll begin to see that California incidence rates begin to exceed those of the US. And by 2019, they're double those of the US. And the vast majority of cases are in males, roughly 4 to 1 males to females. And when you look at congenital syphilis incidence rates compared to the US, around 2012, 2013, so about a year or so after early syphilis rates begin to increase, congenital syphilis rates begin to increase, and by 2020, they're double those of the US. And between 2012 and 2022, female syphilis cases increased over 1,000%, and congenital syphilis cases increased over 1,700%. And by the numbers, that's in 2012, there were 33 congenital syphilis cases and 1 stillbirth. And by 2022, there were 615 congenital syphilis cases, 48 stillbirths, and 11 neonatal deaths. The largest proportion of overall births and number of CS cases were among Latinx mothers, but the highest rates of CS case are among Black mothers. And if you look at risk factors associated with congenital syphilis infants in California, 60% have either no or delayed prenatal care. 44% methamphetamine use, 19% a history of syphilis, 17% have experienced homelessness, 12% incarceration, and 5% other injection drug use. So CDPH asked pregnant women as part of their disease investigation, where did they access support services during their pregnancy? And 25% said the emergency department. So because of that, in March 2022, CDPH put out a dear colleague letter recommending that emergency departments consider implementing routine opt-out testing for syphilis and to take a syndemic approach, HIV and hepatitis C. And we let EDs know that opt-out testing was supported by California's state law and health department recommendations. And that it was an effective strategy to identify infections and begin immediate treatment. And then in September of 2022, California legislature appropriated $15 million to CDPH to strengthen emergency department syphilis, HIV, and Hep C screening, treatment, and navigation to ongoing care. And this is a collaboration between the STD Control Branch and the Office of AIDS. The STD Control Branch is doing the implementation arm and the data evaluation arm of this program. CDPH then contracted with the Bridge program, who is the program that had the MAT testing or not testing, but the MAT programs in emergency departments to get the funding out to as many emergency departments as possible. We funded 28 emergency departments for 2.5 years to implement or sustain screening programs. The program goals: to identify and immediately treat, to help control syphilis, HIV, and Hep C epidemics in California, and to use a syndemic approach to improve system capacity, to further equity, and address social drivers of health. We implemented a robust technical assistance program for emergency departments, including to date, we've done 7 emergency department webinars. We've implemented an emergency department community of practice where we bring EDs together to really facilitate ED to ED discussion about best practices, barriers, and facilitators to those barriers. We offer individualized ED technical assistance, and we've created an ED resource library that we hold on the Bridge website. We've supported local health departments by doing a kickoff webinar with the local health departments to make them aware of the EDs in their local health department that were funded. We offer ongoing technical assistance calls, and when requested, we facilitate ED to local health department collaborations. So what is routine opt-out testing? And I recognize I'm probably speaking to the choir here, but just you know, with routine opt-out testing, individuals need to know that they're going to be tested, and as long as they don't refuse the test, you can move forward with the test. And we offer a script for EDs, encourage them to say something like this: our ED screens all individuals getting a blood test for syphilis, HIV, and Hep C. Please let us know if for any reason you don't want any of those tests today. Routine opt-out testing is recommended as a best clinical practice by CDPH and CDC because it normalizes screening, it removes stigma, and it supports equity. We also encourage the emergency departments to implement EMR modifications to facilitate that routine screening. And as of this summer, more than half of the EDs had implemented the EMR modifications. And which, as many of you probably know, if you participated in that, is a long drawn out process, can take a year and a half, because you have to become prioritized on the IT list of EMR modifications. As an example of the difference, if those of you can see this, we have in light blue on this graph is a high patient volume ED that the providers are doing manual ordering. And the dark blue is a low patient volume ED where they have EMR automated ordering. So you can see the substantial increase in the ordering that happens when the EMR is automated. And the next slide is going to show you what happens when the light blue ED automates. You can see just in 1 month, a marked increase in the amount of tests that get performed. So the current EDSP testing models, all of the 28 EDs are doing routine opt-out testing. This is as of this summer for at least 2 out of the 3 infections. And there was a handful, literally 4 or 5, that were just finally adding that 3rd test over the summer. Most of the EDs are testing patients who otherwise required a blood draw. One ED is implementing routine testing or universal testing of everyone that comes to the ED. And a few of the EDs, typically some of the smaller EDs, are doing just priority populations. And then as far as treatment initiation in the ED, as of June, more than half of the EDs had implemented routine treatment initiation in the ED for at least 1 of the 3 infections, with over 40% implementing treatment initiation for syphilis and over 20% for HIV. The remaining EDs are working towards this, and it is an EDSP, which is what we call our program, EDSP required milestone. So now we'll start talking about treatment initiation. Yep.
Are most of the EDs using the reverse screening algorithm or the traditional screening algorithm, or is it a mix of?
It's a little bit of a mix, but I'd say the vast majority are actually using the traditional screening algorithm.
So they don't have to
wait,
ask who's had a history, who hasn't. It's just more streamlined.
Oh, yeah.
That's what I think.
Right.
Thank you.
Yeah. So I'll talk through some cases. And by the way, is anybody here an ED provider? Or are you all HIV?
I was an ER nurse.
Okay.
So I was actually in the ER when this went live across the street.
Yeah.
So
That was focus.
yeah.
But
well,
yeah.
yeah,
Yes.
but yeah, so it was a very resistant from the in triage, it's done in a very public manner, and asking them if they want like STI testing was challenging to kind of break the current
Welcome.
practice.
We're testing you for this.
Yeah, exactly. So
I can't tell if there's anyone currently in the ED, because they were all invited, but Chris Coyne couldn't be here, so I don't know. Anyway, if anyone's brave enough to unmute and say I'm from the ED, please do.
It's more so because I'll spend more time on some areas if there are some ED folks, and I'll spend less time if it's mainly HIV. Yes,
I think it's mostly us.
okay.
Yeah.
I'm a resident ED at UCSD, and Chris sent me, so logged on.
Thank you.
Welcome.
Yeah.
Thanks. I should say he didn't send me. He offered participation, so I thought I'd catch you between shifts.
Well, great. Well, thank you for coming.
There was a question, did patients have to pay for the tests?
So first of all, healthcare laws require that STI tests be paid for by insurance. So as long as an individual has insurance, then STI tests should be paid for. There are occasionally, of course, patients who don't have insurance, and that is part of the purpose of the funding, is that the funding can be used for unpaid for tests. But often there's an initial kickback for some tests by insurance companies, but then when it's sent a second time, usually it gets paid for. Okay, so we have a 29-year-old MSM who complains of a painful rash on his genitals. Previous medical history and review systems is negative. He has multiple new partners in the last few months. On exam, you see multiple penile ulcerations. And he has a syphilis EIA that's reactive. And question is, what is your diagnosis and should you treat this patient for syphilis today? So as most of us were trained, syphilis was a single solitary ulceration with rubbery raised borders that was painless. But what we are seeing with this current version of this syphilis epidemic is that there tend to be multiple ulcerations, and they can sometimes be painful, which is in part, I think, why the epidemic took off, because we all would say, oh, this is herpes. Yeah. And whether or not we were always testing for syphilis or not up in the beginning, maybe not, but more and more we're seeing these multiple ulcerations. And you can get chancres anywhere an individual is exposed to syphilis. So what we've done is put together these test to treat algorithms for each of the diseases. Since most of you are SDI providers, but we do have somebody from the ED, I'll just walk through this the first time and then we'll kind of move through it more quickly subsequent times. But the purpose of this test to treat algorithm is to say you have a positive test, should you or shouldn't you treat that individual? And what we encourage the ED providers to do right up front is to ask for ocular, otic, and neurosymptomatology, since we know that that often gets missed. So asking those questions right up front, are they having any decreased hearing? Are they having any red eye, blurry vision, double vision, any persistent headache, any, quick look for any ataxia on exam or any other neurologic symptoms? If it's yes to any of those, and those individuals need to go to the right on this algorithm and get the CT-LP workup. If it is no, then you can continue down to your primary and secondary syphilis. Historically, you would think that you would ask those questions first, the primary and secondary syphilis, but we really want to make sure everybody asks those neuroocular and otic symptoms before moving on to just treating them for their primary or secondary syphilis. And then, of course, if they have primary or secondary syphilis, you have a positive test, move forward with treatment with benzathine penicillin G, 2.4 million units IM times a single dose. If there is a shortage, as we currently are in, then you can use doxycycline 100 milligrams BID for 14 days. So these test to treat algorithms are on our Bridge website, and they're intentional to try to encourage and facilitate treatment right there in the ED for individuals. So, first page. Second case, 27-year-old gravida 5 par 4 presented to the ED at 27 weeks estimated gestational age. They complain of a non-pruritic full body rash. They have no recent travel history, no new outdoor activities like going out hiking or anything, no new detergents or self-care products. They work as a housekeeper in a hotel. They have a dog, but they haven't noticed any fleas. And their rash is what you see on the left side with involving palms and soles, and they're EIA reactive. And I can tell you that because I've done a lot of consulting in clinics and in the emergency department with providers, they can look at this rash, excellent providers, some of the top providers I've worked with, and they don't recognize it as secondary syphilis. What I've often seen this called is like leftover scarring from previous trauma, particularly in people with darker pigmentation. So really important to just remember that there's a variety of how secondary syphilis presents, and it doesn't always involve the palms and soles. So any rash that's not recognized should get tested for syphilis. And then secondary syphilis can also just present with mucus patches, patchy alopecia, and then condyloma lata. And I always like to describe the difference between condyloma lata and condyloma acuminata because they can look very much like each other. Little tips is condyloma lata tends to be raised and flat, or condyloma acuminata is raised, verrucous, cauliflower-like 40 type lesions. Not that you can always tell that difference when you're looking at individuals, so testing critical. And so this individual, can you begin treatment on this individual? And again, we'd encourage folks to ask those otic, ocular, and neurologic symptoms first. For this case, those are all negative. This patient doesn't have any primary symptomatology, but they do have secondary syphilis. And so this individual can also move forward with treatment with either that benzathine penicillin G times a single dose or a 14 days of doxycycline 100 BID. And we encourage that treatment start right there in the ED and not wait for them to be referred for follow-up. Okay, so I wanted to take a moment and just share with you CDPH's new syphilis screening recommendations, which actually came out just a little over a year ago. Since this individual is pregnant, I'll just bring that to your attention. All pregnant persons should now be screened for syphilis 3 times. At confirmation of pregnancy, and really confirmation of pregnancy is really important because often what happens is patients get confirmed to be pregnant and then referred for their first prenatal visit, and they never make it to that first prenatal visit. So doing syphilis screening at the time of confirmation of pregnancy is really important. Remember, 60% of individuals have no or delayed prenatal care. Early in the 3rd trimester, as close to 28 weeks as possible, because you need to start treatment in a pregnant woman 30 days or more before they deliver in order for them to be considered adequately treated and prevent congenital syphilis. And then the last is at delivery. So all pregnant individuals should be tested at delivery as well. And then bring your attention down to the lower recommendation down here. Emergency departments and hospital affiliated urgent care clinics should screen all pregnant persons for syphilis prior to discharge. So if you can't prove that they already have a syphilis screen in their chart for this current pregnancy, they should be screened before they're discharged from the emergency department. Just briefly, the other recommendations, all sexually active individuals between 15 and 44 years of age should be screened at least 1 lifetime screen and then offered screening annually thereafter. Anytime you're testing for HIV, any other sexually transmitted disease, or Mpox, you should test for syphilis. And then anytime an individual enters a correctional facility. And then CDPH's recommendations includes encouraging healthcare providers to empirically treat for syphilis while awaiting confirmatory testing if clinically indicated. And I think we'd all agree it's clinically indicated in this particular case. And in fact, the National Syphilis and Congenital Syphilis Task Force recommends same-day treatment based on a single point of care test. So there's support both at the state and national level to treat based on that initial positive test. Okay, one more piece.
There was a question that came up, but I think it was just it was a mishearing. I don't think you said at all that you would treat this person with doxycycline.
It was just the case 2 had like the treatment.
Oh, what
options,
would you
but
do
the-
for treatment?
But I think she was 27 weeks pregnant. So Sarah was just pointing out like,
Yeah.
don't use doxy.
Yeah.
Just wanted to make sure.
Yeah, thank you.
Okay.
Yeah.
Agree, Sarah, yeah.
So now we have one more case, a 35-year-old female who presents to the ED complaining of red eye for the last few days. They've had a headache for the last month and decreased hearing for about the last few weeks. They're homeless, have methamphetamine use, and on exam, you know, this conjunctivitis, which I can tell you, many providers stop there and diagnose as conjunctivitis. This person had a routine screening test and their EIA was reactive. And so should you treat this patient today? And, you know, just back to this algorithm, again, the whole reason why you go through these otic, ocular, and neurosymptomatology, this patient has a persistent headache. They have decreased hearing, which is classic for otic syphilis, and they have a red eye, which is often the first sign of ocular syphilis. So this person needs to have a CT, an LP, including a BDRL, and they're going to be likely admitted and treated with IV penicillin. Okay. So that's, how are we doing on time?
Great,
Good.
8:33.
Okay, great.
A quick question.
Yeah.
I'm thinking about the paradigm shift of trying to get the emergency rooms to just test for HIV. Are the efforts inclusive of things like connecting and educating on, a lot of people don't have access to healthcare. They won't know what PrEP is. Is that a part of the future vision of this work to include, because even if somebody is underinsured or uninsured, they could still access those resources. And if the ER is the only healthcare provider that they're seeing, and those folks are often not trained on PrEP services for obvious reasons, perhaps a future opportunity is an intervention in that same.
Yeah, in fact, a few of the EDs who have been doing this longer have already implemented both HIV PrEP and doxy-PEP. So it is an absolute natural next step. Yeah, and some could say it would be the easier first step, right?
Yeah.
Because people feel more comfortable with HIV PrEP, even though, you know, it's relatively the same as HIV. So, all right, so we'll move to talk about HIV, which again, I think you're all very familiar with, and a lot of this is going to be sort of historic recollection for all of you, so I hope you don't mind. But first, just looking at where HIV, both the rate and new diagnoses were between 2018 and 2022 in California, since the EDSP program was really funded in 2022. Basically, HIV rates and new diagnoses were relatively stable. There was a dip during COVID, as we saw with many diseases that were more routinely screened, but it kind of came back to baseline in 2022. And we continue to see some of the communities that remain disproportionately impacted by HIV in California. Black African Americans, who make up 6% of California's population, accounted for 16% of living HIV cases in 2022 and 15% of new diagnoses. You know, some of the new diagnoses could be part of a screening bias, which would be great. It would mean we're doing a better job screening. In 2022, Latinx Californians made up 40% of California's population, 41% of living HIV cases, and 57% of new diagnoses. And then in 2022, male-to-male sexual contact accounted for 66% of living HIV cases and 55% of new HIV diagnoses. And perhaps most alarming is transgender people have about 23 times higher prevalence of HIV in California using CDC estimates, because we don't have actual numbers for California, but those are using CDC estimates. And in 2022, amongst transgender people diagnosed with HIV, 98% were transgender women.
I have a quick question.
Sure.
In the beginning, you mentioned that some of the EDs have priority populations, and so again, if resources are scarce. So actually, my master's thesis as an ID fellow was doing HIV screening in the ED. What we found in Philadelphia, what we found is people that didn't have a primary care provider, who didn't have insurance, like, you know, didn't have anywhere access to testing, like, were more likely actually to accept testing. And so I argued that if resources are really scarce, that should be the priority population.
Yeah.
So I wonder if that's, that's what's happening, or how are these EDs determining who the priorities are?
Yeah, we allow the EDs to determine their own priorities based on their local epi, based on, the resources they have. So we didn't dictate how they roll out screening or for whom they roll it out. We did share what recommendations were out there from the CDC, from the USPSTF task force, from CDPH, but we didn't dictate that. So I don't know off the top of my head for those that did more priority populations, exactly what populations they were screening. I know, well, I guess I know some. I know one ED started with pregnant women for syphilis, and it was important for them to do that because they had a very high congenital syphilis rate. So I don't know, some of my colleagues may be on if they know off the top of their head what some of the other EDs did for their priority populations, they can put it in the chart or in the chat, sorry.
Dr. Brain.
Yeah, sorry.
I mean, we're an EDSP site. We're not using priority populations. We're screening everybody. And we can, if there's time, we can talk about it. We may be over screening for syphilis. Not over screening, meaning we're not following 18 to 44. We linked it to HIV because we didn't want it to get confusing. Which test do I do for this, even though there's a best practice alert. And I actually was hoping to talk to you about that data, but we can do it in our meeting. And I am planning on presenting the data that we started with back in 2017. I mean, we have almost, 8 years of data now. I was going to present it in August, but lenacapavir came out, so I had to talk about that first. But it is my plan to eventually show, I mean, we just have like heaps of data at this point and sort of how the program's evolved over the years.
Yes.
But that's a really interesting point that you make. Just, do you have a primary care provider? Do you get healthcare anywhere? And that would seemingly be a priority population if resources are scarce.
Great.
Yeah.
And that's one of those kind of things that the EMR could actually pull
Right.
out and flag those people. So, yeah. So back around 2014, 2015, I wrote this article with some of my ED colleagues at LA County USC, which is now LA General Medical Center, changed its name, but same providers. But we really saw at the time the ED's role in ending the HIV epidemic, because at LA County, we could literally diagnose 10 to 15 patients a day. It was huge back then. So now back to some of the historical data. All of you remember the HPTN 052 study where they showed a 96% reduction if you put the HIV positive individual on antiretroviral therapy, drove their viral load to undetectable, that they had a 96% reduction in transmitting from the HIV positive to the HIV negative individual. But in fact, when they did a closer look at the data, they realized that it was actually 100% reduction because the few people who did get infected got infected because the HIV positive individual had just recently been put on antiretroviral therapy and did not actually have an undetectable viral load at the time of the transmission. In addition to that, Skarbinski in 2015 said that even if HIV positive patients are not virally suppressed, HIV infected patients prescribed ART are estimated to be 30% less likely to transmit HIV than those retained in care and not prescribed ART. And this data led to the UNAIDS 90-90-90 targets. And the 90-90-90 targets are that in any country, in any state, in any county, in any city, and I would argue in any facility, 90% of individuals who are HIV positive in that location should know their diagnosis. 90% of those should be begun on antiretroviral therapy, and 90% of those should achieve an undetectable viral load. And this led to the Getting to Zero campaigns for California, New York, Los Angeles, and San Francisco. And eventually they changed these 90-90-90 targets to 95-95-95 targets. And then in 2018, Eisinger, Deffenbach, and Fossey proved that undetectable equals untransmissible. They combined the HPTN 052 study, the Partner 1 and 2 study, and the Opposites Attract study, in which there were over 130,000 condomless sex acts, and found that if the HIV positive individual were undetectable, they had 0% transmitting to their HIV negative partner, which brought up the U equals U. And this led to ending the HIV epidemic, a plan for America. And the goal of ending the HIV epidemic was that there should be a 75% reduction in new HIV infections in the next 5 years, and a 90% reduction in the next 10 years. I think you can look at California's data and question if we've accomplished that, right? You can diagnose, or the goals were to diagnose all people with HIV as early as possible, to treat the infection rapidly and effectively, to achieve sustained viral suppression, to prevent HIV transmission using HIV PrEP and syringe service programs, and to respond quickly to outbreaks. And I'll focus your attention on treat the infection rapidly. So in the US in 2019, we were not doing very well, although we did pretty good with that first 90, diagnosing about 87% of individuals with HIV. When it came down to getting virally suppressed, only 57% of individuals were virally suppressed. So a long way to go to reach our 90-90-90 targets in the US. So why are emergency departments so important? HIV patients are more likely to visit an emergency room than their non-HIV counterparts. EDs are a safety net for HIV infected individuals, and they're often the sole and only point of entry into the healthcare system for some individuals, to your point, yeah. And the rollout of HIV testing in the emergency department paralleled the declines in the rates of undiagnosed HIV in the US. And they made significant strides towards curbing the HIV epidemic in the US. So now looking at some cases, and how are we doing on time?
It's 8:44.
So we'll go, tell me when you want me to stop, because
We'll save Hep C for another time. Is that your thought?
yeah,
Okay.
we can even save part of HIV for another time if we want. And so 45-year-old Black female comes in for a sore throat, abdominal pain, and fever to 101.8. You tell her you want to get some labs today, including an HIV test. You learn that she's an alcoholic and she was raped 3 weeks ago while under the influence. You send your baseline screening labs and she's got a positive antigen antibody test. So what is her diagnosis? I'm sure all of you know, and should you start treatment today? So back around 2012, 2013, the first HIV antigen antibody immunoassay tests began to be implemented across the US. And the thought was that these could identify acute HIV infections between 10 and 21 days post-exposure when patients were likely to be symptomatic and possibly seek medical care for their viral illness. And that's exactly what we found when we looked at 9 emergency departments across the US. We found of the over 800 individuals who were newly diagnosed with HIV, that 14.5% of those individuals had acute HIV. And when we compared that to, at the time, the standard public health testing sites, typically they would identify 2 to 4% of individuals having acute HIV. But when you compared it to a very high risk, high prevalence MSM testing venue, it was between 8 and 17% had acute HIV. So testing in the emergency department, when it comes to acute HIV, is equivalent to testing in a high prevalence MSM testing venue. And likely, of course, for the obvious reasons, right? Patients are coming in with their symptoms of acute HIV or flu-like illnesses. But most importantly, it's an opportunity to intervene with acute HIV. So as a reminder, again, this is all I know, stuff you all know very well, but looking at HIV, if the 0 there is time 0, the time at which an individual gets exposed to HIV and becomes infected with HIV. Initially, there's what's called the eclipse phase, where the HIV sits in that local tissue where that individual was exposed. That lasts for about 10 days. And then at or about day 10, it breaks through to the local lymphoid tissue and then into the systemic circulation. Once in the systemic circulation, there's a rapid ramp up phase of viremia, which results in seeding of viral reservoirs in the CSF, in lymph nodes, and in the prostate in men. There's an intense cytokine storm that results in diffuse body inflammation that puts those patients at risk in the future for hypertension, coronary artery disease, strokes, and cancer. And there's an irreparable damage that occurs to the immune system during that time. And as that rapid ramp-up phase of viremia continues until it hits a peak, there's an increased risk of transmission, anywhere from 20 to 30-fold during acute HIV relative to chronic HIV. And most patients, as you know, present with flu-like symptoms, and they may be presenting to the emergency department. These individuals are antigen antibody positive, they're antibody negative, and they're viral load positive, either by PCR or NAT testing. Are we running out of time? I'm saying a few more minutes. Maybe we'll get through this case and we can always stop here if you want. So early treatment in acute HIV decreases or limits that rapid ramp up of viremia. It limits the size of those viral reservoirs. It can prevent that intent, or not prevent, but it can lower that intense cytokine storm that causes that diffuse body inflammation and puts patients at increased risk in the future for hypertension, coronary artery disease, stroke, and cancers. And it can prevent or lower the risk of transmission if you drive that viral load down. And as all of you know, these individuals seem to be the best individuals to be eligible for the cure drugs that are coming down the pipeline if you get that treatment started as early as possible. And because of this, the IAS USA panel and the Office of AIDS Registry Advisory Council recommend that ART should be initiated as soon as possible after diagnosis of acute HIV infection without waiting for confirmatory testing or resistance results, unless there's suspicion of an opportunistic infection. And so back to our case, just a reminder, abdominal pain, fever, temp to 101.8 and a sore throat. They have a white count of 15,000, 48% neutrophils, 45% lymphs, H&H of 12 and 37, AST and ALT is 130 and 147, BUN and creatinine 15, 1 and 1.1 with an eGFR of 75. So we also developed a test to treat algorithm for HIV. And with any HIV positive test, then the first thing we do is we rule out the opportunistic infections that are most likely to cause IRIS. So Cryptococcus meningitis, TB, and MAC. So this first line, or this first box after a positive test, is to hunt for symptoms that may make you suspicious for those three opportunistic infections. So any critical vital signs, we go through the neurologic symptoms, seizure, new onset seizure, very common with Cryptococcus meningitis, persistent or progressive headache, cognitive delay, in my experience, just long now, you know, cognitive delay, which I might be having myself right now, is, you know, it's one of those very subtle findings that the patient just doesn't quite act like themselves. Their partners say they don't quite act like themselves. When you're talking to them, they just seem like it's just taken them just a little while longer than it should take them to respond. Classic for cryptococcal meningitis. Also, they can get the decreased hearing because of the increased intracranial pressure. They can get blurry or double vision because of that increased intracranial pressure. They can have weakness of extremities if they have a cryptococcoma, and they often will have a very subtle ataxia. So we encourage providers to look for those symptoms and then to look for respiratory symptoms that could be suggestive of TB. So fever, chills, night sweats, typically lasting more than a week, you know, because it's rare that TB patients have those symptoms for a few days before they come in, although occasionally I've seen it, and weight loss in the last month. If it's yes to any of those symptoms, then they go down the right side of this test to treat algorithm, which tells you to hold ART and do workup for those opportunistic infections. If they're no to all of those symptoms and they don't have any critical vital signs, then that's an individual who could begin antiretroviral therapy today. We have them send off, if they don't already have it, ChemPanel, to send off a viral load, send off a genotype and a CD4 count to do a urinalysis and a pregnancy test. If their AST and ALT is less than 5 times the upper limit of normal, and if their eGFR, we picked 40, even though I know you can go down to 30 with Biktarvy, and with FTAP, we picked 40 just to keep a little extra cushion in there. So if individuals have an eGFR greater than 40 and their AST and ALT are less than 5 times the upper limit of normal, then that's an individual, and they're not pregnant, and they have not been on PrEP, then that's an individual who can begin antiretroviral therapy that day and use the standard recommended initial therapies of an integrase-based treatment. Let's see, I'm curious where we're at. So 8:53. What do you
Yeah.
want?
Well, we could potentially stop here. I don't know what's on the next.
Next is
was a
going
new-
to a new case, yeah, so. Right,
I mean, we could stop here. I'm sure there's lots of questions. And probably, well, maybe we could stop here then.
yeah, no.
Yes,
that's
we'll
fine,
do that so we can leave some time for questions.
No, typically, it's hard to get through this whole thing, but I put it all together because you never know, right?
Yeah.
I'm just curious, looking at EHAR's data, the public health data record for surveillance in other states and this one, I don't see acute infection recorded almost ever. So the stage 0 documented negative followed by a positive, rare, but given that we are doing 4th generation testing and we know when people have acute infection, why not?
Yeah, well,
Winston, why not?
Okay, gotta go.
You 100%. I'm chief of the STD control branch.
Yeah.
I don't have control over that. But I will tell you that when I started doing emergency room screening back in 2011, 2012, and we started seeing acute HIV very quickly, right? Because we were one of the first to implement that immunoassay, we made it a requirement for any acute HIV that we reported it to public health within 24 hours of finding that acute HIV. I do think that's what it should be. I don't have control over that.
Who does?
Did that ever change?
Yeah.
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 But yeah, totally agree with you, because that's how we're gonna get to the bottom of the epidemic.
Right,
Right.
I mean, it helps with prioritizing prevention, but it also could identify those people for future cure interventions as they become more.
Yeah.
That's why I don't think it's unintentional. I can't.
Yeah, I just had a question about how the medications, or is there someone in the
It's hard.
emergency departments who have participated in these programs that handles enrollment in ADAP, RINY, whatever program is needed to cover the medications, or have the funds been used to sort of purchase courses of Biktarvy and Descovy plus Tivicay?
Yeah, so.
Sorry, I use brand names.
Different,
Just in the interest of time.
he's doing different things. Yeah, I guess I did too. Whoops, you didn't hear that. So some EDs have gotten starter packs. And I can tell you, I've previously talked to some of these drug companies, and they've given us permission for folks to have 28 days of starter packs, because most starter packs are 7 days. And so you could give 4 starter packs. Insurance, of course, will cover it. Medi-Cal will cover it. So it's really those uninsured patients that you're most worried about. We are doing a pilot right now with our Office of AIDS with just one ED right now, but happy if you all are interested in trying it as well, where there is this like quick sign up for ADAP, like a single page sign up for ADAP, emergency ADAP, that patients can get right there in the ED. And so we were going to pilot it with 1 or 2, if you all are interested, EDs, and figure out how well does that work? Because I think the patient navigators could learn how to do that, since it is a single page, and then they could get signed up and get an emergency ADAP. So yeah, work in progress.
Yeah.
Yeah.
I mean, I have so many thoughts around this, but obviously we don't have time. I think Steve sort of put it very well. The buy-in for this is really big, and there's so many systems that have to come together to make this work. I think our big sell to this very high volume emergency room was, let's just get this testing going. And I think, at least the way things stand right now, anything more, so like immediate HIV treatment, immediate PrEP. I did just we applied for a CDAF grant to try to do immediate Hep C treatment, which I want to talk to you about. That's gonna be, but it takes time, effort, money, all of those things. I think also what we've seen in our experience, and Lucas just left, I think we are pretty good at getting people rapidly over. This is obviously UCSD and Owen Clinic very specifically, and maybe to, you know, some of the other clinics that we see or that are used in the community. We get people on like into a visit where they can start meds quickly. Now I'm only thinking about acute infection, but that's obviously not, you know, that's a smaller percentage of people we're seeing. And I think over time, it feels like we're seeing fewer acute infections. That may be the work of PrEP, that may be the work of a lot of different things, U equals U. So it doesn't feel like there's such a rush to get people on rapidly unless they have acute infection. But we've found in other settings where 30 days of drug is given, they go to pick up their med, it's thousands of dollars, right? No one explained anything to them. And I think it's that time that happens at an intake visit where you get so much information about what this is gonna look like, that in some places is like gets lost in the ED. For some people who are like, oh my God, this is a new infection, you're telling me all these things. So even just like starting meds, I think for some people is very challenging. At least that's the experience I've seen. And because I think if we didn't have the Owen Clinic and other great clinics in the area, we probably would have to do that more. But maybe we've defaulted on our clinics that are like, we know what we're doing here, just get them to us. I don't know, that's the pushback that I've sort of seen over the years, all of those things together.
And I would
But
say
it was a ramble.
for about 70% of the people, that will work.
Right.
Right, but it's really those people that you are the hardest to get on treatment, that are, you know, the people that continue to go untreated, that are driving the epidemic, that really the only chance you're gonna have is right there in the emergency department. And I can tell you, we did it at LA County USC Emergency Department, and I've helped a bunch of folks across California do this. And roughly about 80% will accept treatment right there in the emergency department.
Sure, I think it's it's like you can give someone 30 days of meds, that's great. What happens after that?
Well, yeah, I mean, you have to put in, and that's the point of the navigator and the provider, you have to put in that tight system.
I mean, we have that tight system and I find that still has been difficult. That's
Yeah,
just
it
our,
is,
yeah.
It is, yeah, no, I don't question
Yeah.
that. But, you know, we're also in an era where, the antiretroviral therapy is better than it's ever been.
Right.
So let's say you do give them that 30 days
And then
and they disappear. Well, you've probably controlled their disease for a period of time. When they come back, you can safely put them back on that same regimen. And yeah, most of the time, right, nowadays. So, and we're moving towards injectables, which may be even the ideal situation for this. The one thing I will say, the one thing that ER docs can get their heads around is acute HIV.
Yeah.
To them, that's where it really makes sense to begin antiretroviral therapy today.
I think the problem is also the results, the results won't be back in the 5-hour period that they're in the emergency room.
Oh, you guys don't have results coming back.
No, the antibody test takes longer. The HIV, so the antigen antibody test would
Yeah.
come back reactive.
Yeah, yeah.
So I guess you're saying reactive antigen antibody, you don't have anything else and the person has acute symptoms.
Yep.
That would be a go.
Yeah, and that's
Um,
even what the guidelines are.
Right.
You don't need to wait for that confirmatory
Right.
test. Yeah,
I just wanted to point out our East Campus Hospital doesn't have a discharge pharmacy too, so.
They're also not doing universal
Even
HIV
transitioning
screening
someone
yet.
that's admitted
Opt out.
and they identify that they have HIV, we found cases where they like send their ART to a retail pharmacy and it doesn't get filled.
That's a
No,
whole, that's
yeah,
a
I don't know.
huge, no, it's a
Well,
huge mess and where there's a lot of
It is
opportunity.
like a great transition, but we have this
Yeah,
other
yeah, yeah.
hospital.
I think it's US Health Board, right?
Yeah.
Those are
Yeah,
the,
yeah.
those are the pieces that.
It's not urgent, is it?
Yeah.
But he didn't realize it had gotten so late. I don't know if anyone else has, it's 9:02, so we're sort of done,
Is
but
any genotype testing at all when in this, when you're rapid starting?
Yeah, yeah, if you go back to the algorithm, that's
in there.
part of what they send, yeah.
Yeah.
But you're not
Or,
gonna get
you know,
Right,
US guidelines no longer recommend that you wait for that
Right,
genotype
start.
testing result before you start. You
Yeah.
can start, you know, an integrase based unless they've been on PrEP,
Yeah.
and you need a PI based regimen.
it's like, if we don't get it, and then there's like rilpivirine or some sort of
Usually
acquired
injections.
resistance. Yeah, just like in the future, it's always, you miss the opportunities sometimes hard down the line, but not the end of the world. With
I mean, there are a lot of groups that, oh, go ahead.
And I was
sorry.
just gonna say, I'm someone who loves HIV resistance. I spent,
Yeah.
I literally spent almost 20 years training providers on HIV resistance, so I love it, and I also understand it very, very
Yeah.
well. And remember, even if you put someone on a regimen that maybe they have archived resistance,
Yeah,
so long as you have your follow-up plan,
And find
and you
it.
can, yeah,
Follow-up plan.
it's going to surface and you can find it,
yeah,
so.
and deal with it,
yeah.
yeah.
I was just wondering, has there been anything done for like nursing practice training? It seems very provider focused, but I haven't heard you mention anything about nursing practice.
Excellent point. No, we really haven't. We've been focused on a clinical champion in the emergency department, but we haven't specifically focused on nurses. We encourage the clinical champion to bring both the nurses and the providers on board and do some baseline training prior to implementation. But you're right, we personally have not
I
done
think
that. So
The
thank
issue
you
with
for
that,
pointing
right,
that
is
out.
like nurses are shift workers, so, it's hard to get them coming, they're not shift to
Yeah.
do extra training.
Yeah.
So it has to,
Multiple trainings.
yeah, it's just,
And
and then, yeah, like, I worked at 2 different ERs and one ER was not teaching, and so it's all about throughput. In and out as quick as possible, so one order set, get a differential and then get them out, right? And then like here, obviously there's residents, so you're always doing multiple orders and like evals, because there's the resident and the provider come through. So ordering more stuff was much more common here, but in other hospital systems where there's not residents, I think it's much more challenging to, like, if like the triage nurse puts in an order set for labs and the labs are done, but by the time the doctor sees them, and they missed all these labs, they're not. So, so again, nursing practice.
Yeah, no, thank you. In some of the EDs, I do use the nurses as the triage nurse as where they, do their opt-out testing. So,
And they do that across the street, yeah.
yeah.
Last word,